Welcome everybody to this week's Monday Lunch live stream from the VCCC. My name is Professor Grant MacArthur. I'm the Executive Director of the VCCC, and huge pleasure for me today to MC what is, I think, a fantastic topic which people will have a lot of interest in. I would like to begin by acknowledging the traditional custodians of the lands at which myself, today's presenters and the audience are located. I would also like to pay respect to elders, both past, present, and extend that respect to other Indigenous Australians present online today. If I could have the next slide, thanks. Before we kick off today's program, just a few housekeeping notes. So firstly, today's program is being recorded, and so people are able to view this online through the VCCC Alliance Open Learning page, and you can also see previous Monday Lunch Live webinars as well. Importantly, we very much want discussion today of what is a really very interesting topic, so please use the Q&A function to ask your questions, and please ask them during the presentation, as often they come in a big rush at the end, and in order to get through as many questions as we can, it's good if you could ask your questions during the presentation. Okay, so now a pleasure for me to introduce three wonderful speakers today. Firstly, Professor Dorothy Keefe, who is the Chief Executive Officer of Cancer Australia, which is Australia's national cancer agency. Dorothy is a medical oncologist and is a real world leader in the area of supportive care in cancer. Also speaking today from Cancer Australia is Dr Vivienne Milch, and Vivienne is the Medical Director at Cancer Australia, where she provides strategic clinical policy input to Cancer Australia's work across a range of areas, and importantly, Vivienne is also a medical advisor to Commonwealth Department of Health on cancer screening policy. And she brings a background in general practice to her role. Finally, we'll hear from Professor Eva Segelov. Eva is the Professor and Director of Oncology at Monash Health and Monash University. Eva is an expert in gastrointestinal cancers and breast cancer, internationally renowned. And what has been absolute privilege for me personally is to see Eva in action during the pandemic, where really her leadership has come to the fore, really running a number of initiatives and contributions to our response as a cancer sector to the COVID pandemic and the impact on cancer. So without further ado, I'd like to hand over to the first of our speakers on this very interesting topic of the SerOzNET Oz study, and Dorothy Keefe will kick us off. Thank you, Dorothy.
Thank you very much, Grant. Thank you for your introduction, and I would like to add my acknowledgement to the traditional owners of the lands on which I am speaking today, which is the Kaurna people of the Adelaide Plains. It's obviously very important for all of us to understand the safety and efficacy of the COVID-19 vaccines in people with cancer, and that's becoming more and more relevant as time goes on and we see the issues that people are having with signing up to have vaccines and having accessibility to vaccines. Could I have the next slide, please? Obviously, as Grant pointed out, as the National Agency for Cancer, at the start of the pandemic, Cancer Australia really had to think about what it needed to do to be helpful in a national way and to be helpful to our cancer community. So we saw our roles as multifaceted. One of the things we needed to do was to provide information and communication as well as we could. So we've provided an enormous amount of information for people with cancer about cancer and COVID-19, particularly trying to make sure that all communities were engaged and able to join in the conversations about cancer and COVID-19. So a lot of work with Aboriginal and Torres Strait Islander people, work with our called communities, and multiple sort of advertising and social media campaigns around making sure that people go and have their cancer treated during the pandemic, so that we don't see too much of a surge in delayed cancer diagnoses after the pandemic. We also wanted to look at what the data was telling us about presentations and treatment of cancer. And because we couldn't quite get the data directly, we went around, we created a workaround and analysed the MBS data for what had actually happened during the pandemic. And that's been published multiple times now over the time period, showing the impact of the first wave and then the impact of individual lockdowns in individual states. Next slide, thank you. We also realised at the start that there wasn't actually a pandemic planned for cancer. And so we did some thinking along with some leaders in cancer around the country about how you might actually address cancer care along the cancer continuum during a pandemic, looking at each stage of the cancer journey and how badly affected the health services were by the COVID surge. And so this enabled us to publish this conceptual framework for cancer management. And then we also looked at what would happen in the future. What did we do during the pandemic, and as exemplified by the work that the VCCC Alliance and others have been doing, looking at the good things that came out of the pandemic and the bad things that came out of the pandemic in terms of cancer care, things like increased use of telehealth, things like virtual MDT. So we did quite a bit of work in that area. But then, of course, once we thought through that, the biggest issue that came up was then cancer vaccine, or COVID vaccines and cancer patients. And so I shall hand over to Viv and the next slide so that she can take you through our thinking there.
Great, thanks, Dorothy. And thank you very much, Grant, and the team for having us here today. It's a great opportunity to talk about our work that we've done around COVID and cancer, and now in particular around the vaccine, the COVID vaccine and people with cancer. So since the beginning of this year, the focus of our work at Cancer Australia in our COVID and cancer space has been around the COVID-19 vaccines and their implications for people with cancer. So we knew that from our work to date that people with cancer were more vulnerable to COVID-19 and that that people with cancer are more at increased risk of more severe infection. But we also knew that they were largely excluded from the initial international clinical trials around the COVID vaccines. So in the beginning of 2021, as Australia was about to embark on a national rollout of the vaccine, we undertook a review of the literature, looking at peer-reviewed articles and national and international published recommendations and statements on COVID-19 vaccines and cancer. What we found was a paucity of evidence, not surprisingly, and right at the beginning of our work, there were only 15 articles in the peer-reviewed international literature and 6 organisations who were publishing recommendations, basically saying that in general, the evidence for the safety and efficacy of the COVID-19 vaccines for people with cancer is limited. However, because we knew that there were potential benefits of vaccination, that these would outweigh the known risks of COVID-19 infection and the potential risks of the vaccine, and therefore many cancer organisations recommended that people with cancer would be prioritised to receive the vaccine. Next slide. So what we did then is we gathered together a group of key stakeholders in a virtual roundtable. This was we have had a number of these virtual roundtables, bringing people together. And this time we wanted to really understand what is the information needs, what are the community's concerns around the use of the vaccine in people with cancer. And we found that really the key concern of the community was, what do we know about safety and efficacy of the COVID-19 vaccines for people with cancer? And this really is really the starting point for this work that we're going to talk about today, about the SerOzNET study. So what we did after that roundtable was we put together a list of questions that were based on what our consumers mainly told us they really wanted to know, and the concerns that we knew were being raised through social media. And we put together some frequently asked questions which sit on our website. And those frequently asked questions are updated regularly, probably weekly at the moment, as new evidence and new information from the government's rollout changes. But we also have worked together with Menzies to put together some tailored information with Aboriginal and Torres Strait Islander people affected by cancer. And we've made an animation encouraging Indigenous Australians to get vaccinated, and we put that out on National Indigenous Radio Service. So we've also just finished translating the frequently asked questions into 10 of the most commonly spoken languages in Australia, and we've worked together with the Multicultural Health Service to have those translated, and we released those last week in an effort to get this information out to the communities who need them. Next slide. But really, in the end, we knew that we really wanted to address this question that the community had asked us: are the vaccines safe, and do they work? And what are the awareness and perceptions of vaccines in the communities? And we analysed where the gaps were for information and where there were opportunities for Cancer Australia to help build that evidence. And we undertook some national and international consultations to look for those gaps, and found really that they centred on, if you look at that, the top left box, the red around vaccine safety, there were really questions around short-term adverse events. What was the profile of adverse events in people with cancer? What is the impact of cancer treatments? What were the medium-term and the longer-term health impacts of the vaccine in people with cancer? What was the efficacy in people with cancer? In particular, what different types of cancer might impact on efficacy and specific types of treatments? And what was the vaccine-related patient experience in people with cancer? So in the red and the blue boxes, there were sort of opportunities that we identified that the red one's national and the blue one's jurisdictional, and that really identified, well, where can we find this information? And we, first of all, we looked to AusVac Safety, which is an active surveillance survey that's provided to people after their vaccine and sent out on days 3, 8 and 42 after the vaccine. It's a fantastic resource, and they so far have administered 3 million surveys. However, they haven't yet stratified that by people with cancer. So that's sort of across the population, interesting, but doesn't provide us yet with the answers that we're looking for. We also influenced the POCOG survey and also the 45 and up study to add in questions that were related to the vaccine for people with cancer. Below that line, looking at medium and longer term reporting, we looked at data linkage opportunities of linking data sets, state and territory government and Commonwealth Department and agencies data sets, and try and link those to cancer registries. And we are going to pursue that work, but obviously that all takes time. So next slide. So while this was all happening, we realised that actually what we really needed in Australia was a prospective study on the COVID-19 vaccines and cancer. And we really saw in all the published literature this call for prospective studies. So importantly, you can see on the top left there, the Lancet Oncology on the 1st of June published a paper by the COVID-19 and Cancer Global Task Force. And it really highlighted this issue that how little is understood about the different vaccines in various types of cancers, and that the task force strongly advocates for countries to undertake prospective studies. And there were a number of other studies here, which I've also put excerpts on from identifying that further studies are warranted, that we need research in this area, that clinical trials of vaccines in people with cancer were required. So next slide. So as part of our international consultation, we held discussions with the US NCI, the National Cancer Institute, to talk about what might be international opportunities to build the evidence on safety and efficacy for the COVID-19 vaccines in people with cancer. And the NCI identified that there was a group called the SerOzNET group. They're a group of investigators funded by the NCI, and they were looking at the immune response to both natural infection with COVID and also to vaccination. And there was a subset of those SerOzNET investigators who were conducting an open label, non-randomized safety and immunogenicity study of COVID-19 vaccine in cancer patients in the US. And we talked to them, and they identified that they had a template that they were happy to share with us, which proposed a structure and common data elements for studying exactly what we were looking to find out, which is is the COVID-19 vaccine safe, and does it work in people with cancer? And so we, early on, probably in March, we wrote to key cancer control representatives in each of the states and territories, and we sought their interest in undertaking a prospective study of vaccine response in people with cancer based on this SerOzNET framework. And in June, we were delighted to engage Monash Health and Eva Segelov's team as the lead site to rapidly establish and implement a clinical study based on this protocol. And in Australia, this protocol is being called SerOzNET, coined by Eva's team to highlight the unique population it will study. And it's unique and different to the US population because we have a largely COVID naive group cohort of people. I'm going to pass to Eva now to talk about the study, how it was established, what its progress is, but we are really excited and delighted to be able to have taken this opportunity to provide timely information for the cancer community and build the evidence for the safety and efficacy of the COVID-19 vaccine for people with cancer in Australia. So thanks so much, and I'll just pass to Eva now.
Thank you very much. I will just try and find my PowerPoint to share. One moment. Oh, don't tell me this is doing it again. It did this to me last time. Sorry about this. I just need to open my PowerPoint. Share my screen. There it is. Goodo. And hopefully that will be correct. So thank you very much for that introduction. Doesn't matter how many times you use Zoom, some technical issue will get you. So it's my honour to present on behalf of my co-investigators, an absolutely exceptional team at Monash Health, Monash University and Collaborators, the SerOzNET protocol. Now, this is the version dated 8th of June. It was approved by our HREC on the 23rd of June. And as you can see, the associate investigators, I'd like to acknowledge Liz Ahern, Amy Boddy and Stephen Opat at Monash, Michael Leahy, who is coming on at Royal Perth as a collaborator, and our collaborators at the Kirby Institute, Rainer McIntyre and Stuart Turville, and Professor Corey Smith at QIMR Berghofer. So early on in the pandemic, as Viv said, the medical oncology group was one of those groups that put out a position statement. Really, this was an example of eminence-based opinion, not evidence-based opinion. But as you can see, we're rapidly updating this all the time because at the time there was very little information available. And now I've been privileged to be part of the VCCN network, which also had a major focus once the vaccine became available in getting the message out to our patients to get vaccinated. But the SerOzNET study was very, very rapidly set up. I'll talk about that in a moment, with the aim to explore both the serological, immunological correlates of the COVID-19 vaccine across a wide group of patients with cancer, including blood cancers. And we'll talk a little bit later about what serological and immunological tests we plan to do, but also to document the response to the vaccine in patients with cancer using quality of life measures, patient-reported outcomes, and toxicity monitoring. And I believe our study is fairly unique in adding these to the serological and immunological studies. So this was a protocol that got up and running within 6 weeks, and we actually are trying to publish a short letter just on how remarkable this has been, and one of those spin-offs from the pandemic that we hope will persist. We were able to develop a protocol very rapidly. Liz Ahern had a significant input amongst others. We were able to get ethics through at our site with a lot of gentle persuasion and governance within a couple of weeks. We appointed key staff, and as I say, we've got an exceptional team. And Amy Boddy has taken this on, one of our oncologists, as a part-time PhD. We have a study management committee that consists of the PIs and CIs, but very importantly, I want to mention Jan Williams, our consumer, and Effie Atkins, who is another consumer also involved. And the consumers were particularly important when we were designing how many blood draws we would take, because of course you'd like, from a scientific point, as many as possible, but it has to be acceptable to patients. And we're grateful to Professor Peter Ebling and Miss Kim Rogers as the external people on our study management committee. We also have regular reporting to Cancer in Australia, and I just want to acknowledge the exceptional work of Viv and Dorothy and the whole Cancer Australia staff in supporting us to get this study up and running and providing funding. So here are our key collaborators, and there are other sites being sought in Victoria through an expression of interest that the Department of Health has put out. We would like as many sites as possible, but there are some constraints, and I'll come to that shortly. The protocol is based on this SerOzNET, which is not actually a protocol, it's a sort of a minimum data set sort of framework, as Viv said, that was established so that there would be the ability to harmonise analysis of any studies that people took on. So here is our study design. You can have either vaccine. We take blood before and before the vaccine, and just before either the boost or at 3 weeks for the AZ, at 12 weeks, which is the pre-dose 2 for the AZ, and a post-boost for the Pfizer, and then at 3 months and 6 months, and we have questionnaires and toxicity measurement at various time points. We decided to focus on 6 main cohorts. Those actively on chemotherapy or some combination therapy that included chemotherapy. Those on immunotherapy alone, because we thought there's a question about how well the vaccine may work in those people, or side of toxicity in that group of people. We have a group of people on other classically non-immunosuppressive treatments, such as hormone therapy, bone modulating agents, etc. We have a group of hematological malignancies, and in particular are looking at conditions associated with chronic hypogammaglobulinemia. The survivors really is the category of people actually who finished treatment within the past 12 months. So we thought if we find a problem with patients responding to the vaccine when they're on chemotherapy, we'd be left with the dilemma, well, how much longer after the treatment's finished should we wait before we vaccinate? So this is the 6 to 12 months post-treatment group. And then there's a group, which I'll go into a little bit later, who are allergic to one of the excipients in the vaccines, and we wanted to study those patients. Here's our qualitative data and common data elements time points, and you can see we have the classic EORTC QLC Q30, we have a hesitancy scale, some patient-reported outcomes, and some medically reported toxicity and common data elements. We were very fortunate in having our collaborators agree that their series of healthy controls, healthy volunteers that they'd already recruited were able to be used by us as volunteers, so we didn't have to use any of our precious resource recruiting healthy volunteers. But we are also interested in exploring some other immunosuppressed cohort. I understand an multiple sclerosis cohort at Westmead Hospital, and any others to combine or compare our data later on. Now, I don't need to go into the background and rationale for the study. Viv's done that nicely. So I'll move on just to say that there are emerging data about COVID-19 outcomes for cancer patients. And basically, there is, cancer is not a homogeneous disease, as you will know, and so outcomes vary. Lung cancer patients do particularly badly, but whether that's underlying smoking, poor lungs, etc., is not fully teased out. Now, the data so far about vaccination, we've got data from England and data from France. Most of this is based on the BNT162b2, that's the Pfizer vaccine. There's not a lot of data on the in some of the trials for other sorts of vaccines. But in summary, we think at this stage that patients with cancer do not have quite as good a response as healthy controls, that the second dose is particularly important, and we don't know much yet about the durability of response. We don't have a safety signal that there's excess toxicity so far in cancer patients, but there is quite a lot of interest in looking at patients on immunotherapy, as you would imagine. There's certainly no long-term follow-up. Now, both vaccines have got components in them that we find are commonly in anti-cancer therapy that causes allergic reactions in our cancer treatment units, everything from mild to anaphylaxis. And so there are guidelines, again, not based on too much evidence about vaccinating, how we should vaccinate and particularly observe these patients. There's emerging evidence that even though we traditionally call vaccine response according to serology, so development of antibodies, that both B and T cell immunity is important. And often it's the T cell immunity that's just not studied in vaccine response, and that's what we particularly want to look at in this study. But there is some data looking at, we know cancer patients do have impaired immune systems, and so we are particularly looking at as many measurements as we can actually of therapeutic response to the vaccine in our study. So here's the standard neutralization assays, and I'll just play this little video because it's very cool. This is what they look at in the lab, and we're very fortunate that Stuart's lab has got all the latest variants, and we're way beyond Delta down in the Greek alphabet, although obviously Delta is the dominant and most concerning strain at the moment. I'll share with you these healthy donor results, but ask you not to replicate them. Originally, we had a time point at day 7 post first vaccination, and just as we were writing the protocol, the healthy donor results came through that at day 7, none of the healthy donors had made an antibody response, and therefore we wouldn't have thought that cancer patients would. So we were able to remove that time point from our study. And we're going to do various T-cell assays, which means we have to collect peripheral blood monocyte cells, and that is where some of the expense and the technical expertise and certainly the time comes in when you have large numbers of patients to collect and multiple collections. So we have greater than an 80% power to detect a 10% reduction in seroconversion rate in any of our cancer cohorts with 95% confidence, and we'll be able to do subgroup comparisons. The outcomes are that we hope that we will be able to correlate antibody kinetics and for that matter, T-cell responses with specific populations and treatments, and to contribute to vaccine policy, including such things as the need for a booster or the timing of a booster. So here's our very first patient, and this is with permission. This is a lovely patient of ours who actually uses an Auslan interpreter. He's deaf, and we're very proud that he was our first patient on the study. What have we learned so far? Well, logistics are complex. Our population is very vulnerable, and we cover a very large area of southeastern metropolitan Melbourne, and into also drain a lot of regional areas. We have used interpreters, and probably the first time anyone's had a dedicated talk with an interpreter, and that's done by our medical staff about the vaccine and answered questions. And we've learnt such things as port bloods. Bloods via a port are not very good for our PBMC, so we are actually asking patients for a peripheral collection, but timed as much as possible in with any bloods that the patients are having for their next treatment. As I said, we're looking for extra sites, but the funding, like most investigator-initiated trials, does not cover the full costs. So there has to be some in-kind contribution. Some sites have said to us that they have very high vaccination rates amongst their patients. Now, I'm not sure if that's just perception or reality, but certainly we're hearing different messages from different sites. And indeed, the main value, or one of the main values of this study, is having a pre-vaccination blood. There are other studies that are collecting blood at any time point with patients mainly already vaccinated. So what have been our observations in our population at Monash Health? Many patients remain unvaccinated and hesitant. I was telling Viv a story that a patient said to me, I don't need the vaccine. I've always been well. I feel very healthy. And I had to say, look, that may be the case as you perceive it. It's fantastic, but you have metastatic pancreatic cancer. You are in a vulnerable group. We've found most patients absolutely welcome the assistance in booking the vaccine. So patients have found this a very hard system to navigate, and even people who said we'll go to our GP or we'll book it ourselves usually ring up within a few days and say, please, can you book it for me? Many patients will only want one type of the vaccine. Obviously, that's the Pfizer, and I'll show you some data from our current recruitment. Patients who don't speak English as their primary language appear to have difficulty accessing specific information. I think there's general information, but specifically, how do I get the booking? Is the vaccine right for me? And we've had a lot of patients tell us that their understanding was that their doctor told them not to have the vaccine. So this is everyone from GPs, patients who are about to undergo surgery, patients having radiation therapy told to wait till after that's finished. Lots of patients saying to their oncologist, I have to ask my cardiologist. One said they had to ask their rheumatologist. So I'm not sure where that puts us in the pecking order. So we have offered this to all our oncology and malignant hematology patients at Monash Health, meeting the criteria of those cohorts I showed you earlier. They've been offered involvement in the study through clinic visits, including telehealth, by their consulting clinician. There's also been flyers, and we're about to start an SMS campaign as well. Some of the carrots we've been able to offer is that we can vaccinate people on site at one of the Monash Health sites at Clayton, and we're able to offer their carer or family member vaccination at the same time. We have some absolutely exceptional coordinators, Laxi Lal and Heshan Abdullah, who call all the patients. We have our trials fellow, V. Luong, and Amy Body, and many other people involved to support patients through the medical questions. We've booked interpreters for many patients who've had questions, and it includes patients who speak good English but want their family to understand, and their family need interpreters. So as of the 29th of July, so the end of last week, we had 192 patient details sent through us by their clinician saying the patient was interested in participating. We've actually enrolled 75 patients on study. So remembering this only started right at the beginning of July, and we've got about another more than that now booked to come in the next few weeks. I'll show you the declined reasons shortly. And interestingly, a number of people, by the time we contact them, say they've already gone and got vaccinated. So just by offering them the study, we may be helping them. We've had 16 patients we've used interpreters on, of those on study. And interestingly, about 36 of the patients sent through who were over 60 would only accept a Pfizer to go on the study if they got a Pfizer vaccine. So there are some logistic issues we've come across, either the volume of blood, which is about 45 mils per draw, or frequently needing to travel to 5 blood draws over the 6 months. Some patients just bewildered, and others where we've had no actual reason recorded, they've just decided not to participate. Here's an example of what our coordinator Hesh documented from one patient keen to sign up. Sorry, this was the information sent through by the consultant, keen to sign up to SerOzNET, may start chemo in a few weeks. Then Hesh has written, he's called, no answer, sent SMS, called again, no answer, called again. They're starting chemo on the 28th of the 7th. Patients very hesitant about the vaccine affecting the chemotherapy, but they wanted the PIC emailed. They'll read it and decide if they want to join, and they'll wait till their next rest week off chemo. They rang back and declined, and then they called back again. They'd changed their mind. So we have a booking for them to come and give consent, have their bloods and vaccine for this patient and their husband later this week. So it's not an easy enrolment, and it requires a lot of discussion and going back and forward. So some data about the patients we've enrolled to date. Most of them have had Pfizer, but a significant number also AstraZeneca. Most have only just had their first dose. We've only just started, and most of that was administered in our Monash clinic and a little bit in a GP clinic, and none at any of the other venues. We have mostly females and mostly patients with very good performance status. Here it is by cohort. Most patients are on current chemotherapy, but we've recruited to all the cohorts to date. Here's some interesting data. Most patients had not already got their 2021 influenza vaccination. Now, this is in July. Distribution of all ages. And we, in particular, trying to look at elderly or frailer patients because they're the sort of people who often don't get included in some of these studies where, yes, there are a lot of visits and we don't want to inconvenience patients, but we really do want to know their data. It's no use having a group of very healthy 50-year-olds. Here's our languages spoken at home. So just about over 20% don't speak English as their language they use at home. And about 5% of our patients don't have access to email through any means, family member or other. We have a wide group of patients, including a large Asian population and Americas. We have enrolled several Indigenous patients so far. And interestingly, here is by smoking status. Here's the cancer demographics just on the first 57 patients. You can see we've got a big spread of different cancers being represented and also a big spread of stages. And this is doctor determined stage or from the records. Treatment intent is palliative. I do need to reconcile that with the majority being stage 1. So there's very early data, as I've said, we need to verify. But we even have things like we're particularly recording steroid dose as in case this affects the immunological response to the vaccine. Quality of life, we've got this very rich data set that we will have serial measures on, and I think that will be really important. We've got patient completed toxicity as well. Not only pain and fever, but things that the national survey may not have collected, like have you had to stop or delay your anti-cancer treatment since your vaccine? Have you attended the emergency department since your vaccine? That's quite interesting data there. Or have you had to start a new treatment for a blood clot? We've also done some hesitancy work looking at patients' attitudes. Don't forget, all of these patients are going on a vaccine study, but hesitancy covers the whole spectrum from not hesitant to very hesitant. And we're looking at the reasons why they want to have the vaccine. So once again, I'd like to acknowledge my co-investigators, my wonderful study team, and thank Cancer Australia for the opportunity to conduct this really groundbreaking study. Thank you.
Thanks very much, Eva. That was fantastic. And thanks also to Vivienne and Dorothy. If all our speakers could turn their videos on, we'll move to a Q&A. And what I think I'd like to do is to sort of firstly talk about the study itself and its design, and then we'll go on to some of the really interesting issues that have come up, including those in the chat. So just to remind people, there've already been some questions put into the chat. You can use chat if you wish, but also the Q&A function as well to ask your questions. So Eva, we might kick off with just some questions about the study design, and I might take Chair's prerogative. So I always, in any cohort study, ask about ascertainment bias, and what do you think, might be your ascertainment bias with this particular study?
Well, it's interesting because there's almost no one who is not recommended to have a vaccine. And so some of the biases we have about putting cancer patients on clinical trials, etc., are not there. Having said that, we do ask for the patient to have an estimated survival of 1 year, because we want to collect the serial bloods. It is interesting, we had one patient who signed up for voluntary assisted dying who wanted the vaccine. So people, even at the end of life, want, you know, some patients want to choose how they want to die, and they're frightened of getting COVID and dying from COVID. So that's important. It's really been widely offered to our patients, and we've really made an effort, as I said, not to exclude people who generally find it difficult to access clinical trials, so non-English speakers or people with transport problems. You know, we've really tried to troubleshoot anyone. We've got one person who's a refugee, not a refugee, a non-Australian, non-refugee. You know, but the Australian government has said they will vaccinate everyone in the country. So we've said, yes, that person can come on irrespective of their immigration status.
Yeah, I guess one sort of ascertainment bias that is pretty obvious to me is where we're at in the vaccine rollout, right? That, you know, we've had a phase 1B designation for basically this study population. And so we would have liked to think that many cancer patients have already been vaccinated, but clearly not, because you're recruiting really fast and really well. So, yeah, do you think that creates any sort of ascertainment bias?
Look, I think it does, you know, and there will be certain groups like patients who had CAR-T, although there's quite a number of studies on those particular super high-risk groups, bone marrow transplants. We're aware of a couple of Australian studies and certainly some international, so they'll be covered by that. As far as, and yes, it may be that people who get vaccinated earlier have a better response. We can never exclude that, but we're getting a wide cross-section of patients. And, you know, there are a lot of patients who haven't had their vaccine, not because they don't want it, but because they couldn't access it. So I think in some ways that mitigates against that type of ascertainment bias.
Right. Now, Anna Holmes has raised an interesting question is, are there any studies that are looking at serological and immunologic responses for patients that are further out from active treatment for 12 months?
Yes, so what we assumed was that these patients might be more like the normal population, and that without knowing what the response was of patients on treatment or soon after, we didn't want to use our valuable resources on a group that we thought were going to be more similar to healthy volunteers. Now, I think that'll be a really important group if we find impairment to then look at staging over, but we had to be strategic, and certainly people on treatment at this current time, if you are going to have a poor response, it is more likely to be then. It's not to say those people, survivors, are any less important at all. It's just that it made sense that they would be more like a patient who didn't have, you know, a significant illness currently or treatment currently.
Great. So I might just ask another design question so that I'm sure people are sitting there thinking about. So, you know, everyone at virtual barbecues around our nation at the moment is talking about AstraZeneca versus Pfizer, right? It's John Howard's old, you know, barbecue chat topic. And so, what do you think you're going to be able to make much comment in the different cohorts about Pfizer versus AstraZeneca?
Yes, look, I think so. And I think as time goes on, more people will be getting AstraZeneca because of what's happening in Sydney, even though we're in Melbourne. More data is emerging. There was a publication just last week showing clotting equal for both vaccines. I've got to read the full paper, but Pfizer, interestingly, in younger adults seems to have more toxicity, particularly myocarditis, and so we're quite interested in getting the AYA group on our study. We enroll over from 18. So I think there's certainly a very prevalent message that we should only have Pfizer. All our cancer patients, doesn't matter what phase 1 study they're going on, they still want Pfizer because of this perception. But I think that will change reasonably quickly. And it will either change because people get AstraZeneca or because we'll get more Pfizer, and most people will have Pfizer. But we do have these two groups, and that's an advantage over other studies.
Absolutely. So there's a series of really interesting questions from Susanna Morris. Thank you very much, Susanna. And I might put these out to Vivienne and Dorothy as well. So Susanna raises about a point about reaching out to other consumer organisations around the country. And, you know, I think I find that quite an interesting question because ultimately, the outcomes of this study are going to provide some really useful data when we think about our messaging and communication to patients nationally. And so maybe either Vivienne or Dorothy just talk about what the opportunities there might be to reach out to, you know, consumer representatives in a national study when we look to interpret and implement some of the potential outcomes observed in this study.
Grant, that is a really interesting question, and I have to admit that is something we're going to have to prospectively plan for, because what we spent the first sort of few months doing was trying desperately to get this study up and running before all the patients had got vaccinated, and there's this ongoing tension of will we get enough patients, or will they all have been vaccinated? And it's clear that we will get enough because they haven't all been vaccinated. And we are trying, Viv's been working really hard with all the jurisdictions to try and get some other sites up and running. But of course, as time goes on, those other states are saying, oh, well, maybe all our patients will be vaccinated, we won't have time to do it. So I think we've really hit a golden opportunity with the team at Monash, and we are incredibly impressed. This must be the fastest study from conception to first patient that I've ever been involved in, and so I should think most of us have ever been involved in. So that's really good. But of course the problem is the other jurisdictions, and some of them are saying, no, we don't have any patients that would be relevant to you. But I think that is a really good point, having a conversation with more of the consumers. I mean, we don't do anything, as you know, at Cancer Australia without consumers, but it might be time to have a little session with a broader group of consumers to think about what we might do next, because obviously there's only a very narrow window for this, and we're in it, so we're doing it now. Viv, I don't know if you want to add to that.
Yes, thanks, Dorothy. Yes, it is a really interesting question, and thank you to Susanna for your questions in the chat. So when we developed the frequently asked questions and we first got those up on the Cancer Australia website, I met with with representatives of many of the cancer consumer organisations to tell them about the frequently asked questions, and many of them link to our FAQs, which is great. Those are updated regularly, and we have a question about how is data collected on cancer patients around the vaccine, and we have committed to updating that if we see any safety signals internationally, and to watching the publications. But we also have a link to a web page which we have on this SerOzNET study. So our plan is to communicate, I guess, through the FAQs with the community, and we will be, as soon as we get any results from the study, we will be able to communicate that way. But I agree that I think it's important to keep communicating with the consumer organisations, because a lot of consumers go to those organisations for their information, and we want to make sure that we're all sort of speaking from the same, singing from the same songbook. The other thing is that we do know that there, this whole question about, which Susanna's raised about, GPs saying, oh, you should go and ask your cancer doctor, the cancer doctor saying, go and ask your GP, not really sure, conflicting messages. And so we have tried really hard to promote those FAQs to GPs. We put them out through the GP press, and to try and improve the amount of evidence-based messaging that's actually getting out there, and that continually gets updated. So yeah, so they're very important questions, and you can't blame people in the community for being confused, because the messages can be different from different people in their healthcare team, and different from in different places that they read online.
Yes, thanks, Viv. Eva really pointed out as well this conflicting messages that's with some healthcare professionals and doctors advising against vaccination, which I think has surprised us all. Comments from Eva or Dorothy about other things we might do to try to get the evidence-based messages out to all medical practitioners, because I think we've been very surprised at some of the disparate views coming from our colleagues.
Go, Eva.
So, I think it's not clear whose responsibility it is, whether it's the GPs or the specialists, and GPs traditionally vaccinate people. So I think it really, there's no ownership of who and I think that's where confusion comes, or multiple specialists. I think it would be important to have a statement from the radiation oncologists, and apologies, but I haven't seen any position statements from that group about patients on radiotherapy specifically. And so I think the comments we've seen from GPs is they're scared, they don't want to make a mistake. And I think on the oncologist's point of view, it's an additional part of the consult that has not really been agreed to by anyone or any training provided. So I'd like to see us own it and give training and how to talk to a patient about vaccination. Should you even be making sure? Should we be ticking it off somewhere, like we tick off Hep B? We've checked Hep B. None of that is yet in place.
I think that's a really good point, Eva. And I think it is our responsibility. And I think we might take a little note that we might need to do some work on this, because it's not fair on the GPs to ask them to have enough knowledge about what our treatments do to patients to then therefore make a decision. So I think it's very easy to say this is oncology's responsibility. The fact that we don't actually know the answer makes it harder. And I was very interested in your sort of hierarchy of specialists. So a friend of mine who's the president of the Australian Rheumatological Association was talking about their issues with vaccine recently, because of course their patients have all the same, or a large number of the biologicals that ours have. So there is a problem for them as well. And I think actually it's our job. And you're right, we need to make sure that there isn't a communication chasm, because I think there is a communication chasm at the moment. The poor patients fall down the middle. And then every time there's a miscommunication, more people throw their hands up in horror and say, well, I'm just not doing it. And I think that's really dangerous for the individuals and for the community. So I think we have a responsibility there. Maybe that's another project we need to get onto.
Yes, it really has been a remarkable time where we've had this interesting interplay between media-led health stories versus, health information provided by healthcare practitioners and official agencies, and we've never really quite dealt with anything with such high media interest in a health issue before, and I think that'll be part of the learnings when we look back retrospectively about this pandemic, which we must say is a ways off yet before we'll be putting on the retrospectoscope, unfortunately. So look, we're up to time, and I'd really like to finish by thanking all the presenters today. I think that was really engaging, a vital topic in cancer care at the moment. On this screen here now, you can see upcoming events for the VCCC. For the Monday lunch live stream, there's improving outcomes for men with prostate cancer through imaging. We celebrate some remarkable young PhD graduates with the Picky Awards the following week. And then what has been really a fantastic series, I recommend to everyone, the Head and Neck Cancer Ethics Seminar series, which has been, particularly interesting. So thank you very much for your attention today. And today's seminar is available through the VCCC Open Learning page, and you can access that through the VCCC Alliance website. So thank you everybody for joining us today.
Thanks, Grant.